presenting two clinical studies which have been published in the recent journal. And the moderator of today's would be Dr. Neeraj Agarwal, who is professor in Department of Urology at our center. And today we have a special invitee with us, Dr. Amlesh Seth. So Dr. Amlesh Seth doesn't require an introduction, so I haven't given much in the introduction. So he is presently the head of the Department of Urology at All India Institute. He has published a lot of work, and he has a special interest in neuro-oncology. So definitely, I think today our residents and all the viewers would be benefited with the interaction following this presentation. So with this, I would request Dr. Neeraj Agarwal to kindly moderate the session and invite the presenter, please. So Neeraj, go ahead, please. So please unmute yourself. Yes, go ahead.
Good evening, sir, and a warm welcome to Amlesh, sir. Sir, it's a pleasure to have you in our academic program, sir. I'm sure the residents would be benefited by your immense experience and knowledge, sir. Naveen, are you ready with your presentation?
Yes, sir, I'm ready, sir.
Okay, I'll invite Naveen Vaishnav to present his journal club. Over to you, Naveen.
Thank you, sir. So, good evening, teachers, seniors, batchmates, and juniors. Today's journal club.
I would interrupt just here. So after the first presentation, we can just stop and have comments from Dr. Seth, and then we can do the second one, right?
Okay, sir.
Okay.
So my first topic is active surveillance for risk stratification of all small renal masses lacking predefined clinical criteria for intervention. This is preface of the journal. And need for the study, it is to balance between the treatment delay and over treatment comorbidity, especially in this COVID session, and to elucidate risk during active surveillance with growth dynamics and histopathology for knowing the at-risk patients. Material and method. This study was done between January 2013 to September 2017, and it was done at Journal of Urology, Department of Urology, Roswell Park Comprehensive Cancer Center, New York. It was published in the Journal of Urology this year, and the number of patients included were 123. Median and mean follow-up period were 31 and 34 months respectively. This is the study design. Here I will separately tell the inclusion and exclusion criteria, but for time being and study design, it included all dialysis non-dependent patients, clinically localized small renal masses patients. Then they were divided into two categories, and they tried to identify the PCI criteria, that is progression criteria for intervention, which is mentioned separately in the blue box. I will explain it. If patient doesn't have this PCI, he doesn't fulfill this PCI criteria, then he can undergo the active surveillance criteria. And during this active surveillance, he will be further examined at a frequent and certain interval. If he doesn't develop PCI, then he will continue with the active surveillance. If he develops PCI meanwhile, or even at the initial presentation, then he will undergo treatment if the life expectancy is more than 15 years. If life expectancy is less than 5 years, we can again take active surveillance or observation criteria. And if the life expectancy is in between the 5 and 15 years, then the decision will be independent decision patient to patient. Now, what is progression criteria for intervention? The criteria above which we need to intervene. Those are, as per this study, the longest tumor diameter is more than 4 centimeter, elevated growth rate, which is if the tumor is less than 3 centimeter, then more than 5 mm per year growth rate. If the tumor size is more than 3 centimeter, then more than 3 mm per year growth rate will be required. These two criteria are for benign disease, and which is percutaneous biopsy proven. If another criteria is the tumor stage, which can be more than T3A, clinical T3A, or unfavorable RCC histology or the symptoms. Here I would like to especially mention if the patient is having a high risk hereditary RCC diagnosis and the longest tumor diameter will be more than 2 centimeter and the growth rate for more than 5 mm per year for even the tumor of less than 2 centimeter. That will be PCI for hereditary cancers. And here we can see the exclusion.
Naveen, 1 second, 1 second.
Yes, sir.
This biopsy, because that part you have not clarified, whether biopsy was a part of the workup or it was done selectively, and if selectively, then what were the indications for doing a biopsy?
Sir, it was selectively in near 71% patient, and the biopsy criteria I will explain in further. That was for more than 2 centimeter SRMs. So 71% patient fitted in that criteria, and those underwent biopsy, sir.
Okay, so biopsy was done at the outset, right before beginning the observation.
Yes, sir.
In
Yes.
71% of the patients.
Yes, sir.
Right.
And all those who had more than 2 centimeters, they underwent a biopsy. Okay.
Yes, sir.
2 to 4 centimeter. Yes.
Okay. More than 4, they underwent surgery. 2 to 4, they underwent.
Yeah.
Okay.
Yeah.
Shall I proceed, sir?
Yes, please.
Yes, sir. So initially the patient taken were 165, but some patients were excluded, and the exclusion criteria were if death prior to first follow-up, if they elect the outside care, if they have prior RCC treatment, or there is dialysis dependency. So finally patient they got were 128. Out of those, 5 were presented with PCI criteria. So they underwent the intervention. Now we got 123 patients which underwent active surveillance, and out of this 123 patient, 70% patient, that is 86 patient, were on active surveillance criteria, and among this 86 patient, only 1 patient underwent to DI, that is delayed intervention, that too due to anxiety of that patient, and other patients were on the active surveillance. Now out of this 123 patient, 37, that is 30% patients were detected as the PCI criteria, and they, out of those 37, 29 patients were converted to DI, that is delayed intervention, and I will be discussing later that all of those have the aggressive RCC histopathology. Among patient criteria, the median age was 65, and the male-female ratio were almost equal. And regarding GFR, most of the patients were above 60 ml per minute GFR, and their almost right and left laterality was not significant. The inclusion criteria were patients with small renal mass and non-dialysis dependency, non-metastatic, clinically localized, and contrast enhancing masses without hereditary RCC syndrome, seen by only 1 urologist at a comprehensive cancer center, and lacking standardized progression criteria for intervention in the beginning, and delayed intervention recommended only upon progression criteria for intervention development. Exclusion criteria: dialysis dependency, prior RCC treatment, PCI positivity at presentation, elected outside care, or death prior to first follow-up visit. The active surveillance, what was the active surveillance regimen? It comprises of abdominal CT or MRI if contraindicated, and chest X-ray were obtained after 6 months for if the tumor size is less than 3 centimeter, or if the tumor size is more than 3 centimeter, then this can be done at the 3-month interval. Subsequently, at 6-month interval, and at the end of 3 years, if there is no PCI development, then they can be followed with the ultrasonography. This is for low risk patient. For high risk patient, if the tumor size is more than 3 centimeters, then we will start at 3 months, and 3-monthly regimen for the CT scan or MRI will be taken up. And the biopsy here, it is mentioned in percutaneous biopsy was recommended for patient with the tumor size of more than 2 centimeters or the growth rate of more than 5 mm per year if size is less than 2. The benefit of study: oncologic risk stratification can be done by growth dynamics that correlate with the metastatic potential. And we can have the facility of percutaneous biopsy. And favorable factors here were negligible metastatic potential if the longest tumor diameter is less than 4 centimeter and slower growth rate was there. Outcome measures baseline clinical features, biopsy histopathology, and radiographic tumor size. And measures included the rate of PCI and DI negativity, PCI and DI free interval, and metastasis and adverse pathology will convert into DI resection, that is delayed intervention resection specimen. And the results were result is divided first for growth and biopsy outcome. Most patient underwent biopsy, that is 71% will develop the RCC, 23% have benign, 6% have non-diagnostic, 35% patients showed no growth during active surveillance. Median growth rate was 1.1 mm per year. 18% showed more than 5 mm per year growth rate, and more than 8 mm, they all show RCC, clear or papillary type.
Naveen, sorry, I come back to the same question.
Yes, sir.
Because you said that 71% of the patients had biopsy. Whereas
Yes,
from this slide, it seems that all the patients had a biopsy done. Because here it is that 71% had RCC on biopsy and 23% had benign and 6% had non-diagnostic. That completes all the 100%.
Sir, it was written that most AS patient. That's why I was confused. Most AS patient. They didn't mention all patients. So
Okay. Here you should give the number of out of these 123, how many underwent a biopsy, and so these results are for those that n is equal to whatever 89 or 88 or whatever it was. So here you should indicate that.
Yes, sir. Sir, I didn't.
So actually, Naveen, how many patients had less than 2 centimeter tumor, which had a growth rate of less than 5 mm per year? Those were not biopsied, right? So actually, what was the number of these patients?
Sir, it was mentioned in percentage only, sir. This was the direct.
What was, how many of these were not biopsied?
Sir, it was mentioned 70 to 71% underwent biopsy, sir. And so the rest of the patient, I assume, sir, they didn't underwent.
71% had RCC, or 71% were biopsied.
No, sir, this is 71% RCC. 70 to 71% also underwent, sir, biopsy.
Okay. So the same
70% data.
Okay.
So despite a diagnosis of RCC, they were continued on active surveillance?
Yes, sir. As per PCI criteria, sir, if the growth dynamics is less and the type tumor size is less than 4 centimeter, then only, sir.
No, but in the earlier PCI criteria, you have said that those who had a non-malignant diagnosis on biopsy. You go back to your first slide.
Sir, that was for first two criteria, yes, sir. This one, sir.
No, go back one more slide.
Sir, I guess I have made a mistake, sir. These are for all, sir.
Pardon?
Sir, so this criteria is for all patients, sir, not for benign only, sir. I have made a mistake. I'm sorry, sir. This criteria are for more than 4 centimeter, for more growth rate. All of the patients, sir, whether they are benign or malignant, sir, they all underwent some kind of regimen, either continued active surveillance or delayed intervention, but they all will be taken under consideration of PCI positivity.
No, there is a star which says in absence of benign neoplastic biopsy histology.
Yes, sir.
So one star is for tumors who are more than 4 centimeter, or they had elevated growth rate, but they were not benign. So that means that, Pradeep. On histology, they were not benign. And if it is more than 4 centimeter or more than 5 millimeter growth rate, they were considered for intervention.
Yes, sir. And if they are less than, if they are benign, then the continue and active surveillance will be there. not the
Right.
delayed intervention, but active surveillance will be there.
Right.
So this means despite the presence of RCC on biopsy,
Yes, sir.
patients who had a tumor which was between 2 to 4 centimeters,
Yes, sir.
they were, and there were some patients who were more than 4 centimeters. They were also continued on active surveillance.
No, sir. They all are
No.
initial presentation. They are fulfilling the criteria of PC positivity. Then we will look for the life expectancy. If it is less than 5 years, then observation can be done. More than 15 years, then treatment, and 5 to 15 years life expectancy. Patient to patient decision has to be taken as per authors.
I think we are taking SRMs only. So for more than 4 centimeter, definitely ruled out. Right? So we are taking patients only which are less than 4 centimeter, right?
Yes.
And those who will have a biopsy report of RCC, even if the size is between 2 and 4 centimeters, they will undergo surgery. They will undergo surgery or some ablation, one of the treatments. That is, they will not be candidates for active surveillance because these are patients who otherwise are fit. In your study inclusion criteria, you have already taken patients who are fit.
Yes, sir.
You have not taken patients who are who have less than 5 years of life expectancy or those who are dialysis dependent.
Sir, in this journal, sir, for even for 2 to 4 centimeter RCC patient, even if they are not fulfilling PCI criteria, they underwent, sir, treatment or surveillance.
Active surveillance. They are probably, if it has a favorable RCC histology, then they are putting these patients under surveillance, unless it is an unfavorable RCC histology. So have they defined the favorable and unfavorable RCC histology?
Yes, sir.
Naveen, what is that favorable and non-favorable?
That is for grade 3 and 4 patients, sir.
Okay, 3 and 4 would be unfavorable and 1 and 2 will be favorable. So favorable would be under active surveillance, unfavorable would be for surgical intervention. Right?
Okay.
Right. Go ahead. Yes.
Benefit of study was oncologic risk stratification as per growth dynamics, and favorable factors were the diameter size of less than 4 centimeter and slower growth rate. And outcome measures were baseline clinical features, biopsy, histopathology, radiographic tumor size, and measures were PCI and DI negativity, and the metastasis or adverse factors were nuclear grade 3 or 4, and PT3 is the adverse factor. The results were for growth and biopsy outcome. Most AS patient underwent biopsy. 71% were RCC, 23% benign, 6% non-diagnostic. 35% showed no growth during AS, including occasional regression also. And median growth rate was 1.1 mm per year. 18% showed more than 5 mm per year growth rate. More than 8 mm per year, all patients showed RCC. In terms of progression outcome, none of the patient developed metastasis. 30%, that is, and the 30% patient developed PCI criteria in average 17 months, and the median total longest diameter increment in PCI positive and negativity were 0.7 and 0.2 centimeter per year. PCI free survival rate were at 1, 2, and 3 years were 92%, 76%, and 72%. Here, worse outcome factors which will that are defined were initial longest diameter if more than 3 centimeter, then 3-year survival rate is 49%. If the initial volume is more than 5 centimeter cube, then the survival is 61%. If clear cell RCC, then 45%. Initial renal score more than 7 mm, more than 7, it is 63%. And if non-occasion race, it is near 50%. In terms of DI outcomes, that is delayed intervention outcomes, out of 30% patients, the PCI positive patients.
Naveen, just go back to the last slide again.
Yes.
Here you said that there was 49% survival rate in those patients who had longest tumor diameter of more than 3 centimeters.
Yes, sir.
49%, which means 51% of these patients died.
Yes, sir. That is, but our study criteria is up to 4 centimeters. Sir. It is for more than 3.
No, survival, because, number one, you said that none of the patients developed metastasis.
Yes, sir.
So they would not have died of RCC.
Yes, sir.
They might have died of something else. But here you are talking about survival of 49%, 61%, 45, 63, and 50%. I mean, this is something which is not clear to me. How is the survival so less? Why is the survival only 49%, 61%, 45% when no patient has developed metastasis? And baseline, your patients were reasonably, they were not unhealthy patients. You had not taken patients who were, poor surgical patients.
Yes, sir. General health.
Naveen, actually, I think we need to go to the study maybe to understand it properly, because this cannot be, this is not possible, because many of these patients who are kept on active surveillance might be having more than 3 centimeter diameter, and 50% of them died at 3 years. This is, I don't think, possible.
So this
So,
can be those patients which have a life expectancy of less than 5 years at initial. So this can be those patients who are PCI positive, but still they have life expectancy of less than 5 years in the initial presentation.
that you haven't said, no?
They have
You are saying only with initial LTD more than 3 centimeter, they had a survival rate of 49%, and that too at 3 years, which is not understandable. We might go through the study maybe again, but anyway, we need to. Dr. Neeraj.
Sir, even I think he has misinterpreted the. It should not be 3 year survival rate. I think it should be a progression rate, or advancement in the size, because even in large tumors the survival is not that low.
Yes.
Even in large RCCs, which we do, the 5 year survival rate is quite high. It's more than 50 to 60%. So how can it be just 49% a 3 year survival rate? So I think he has Naveen?
Yes, sir.
I think 3 year survival rate nahi hona chahiye. Isme it should be something else.
I will recheck.
Was it really given in the article, 3 year survival rate?
Sorry, as per I remember, sir, yes, it was given, but I will recheck, sir.
And actually, I will go to the conclusion of the article, which says that broadly recommended AS active surveillance among PCI free, otherwise unselected SRM patients is a novel approach that can identify at-risk cases for selective intervention and smarter treatment selection. Particularly in the current COVID-19 pandemic era that has been marked by treatment delays for unconventional reasons, it is reassuring that recommending active surveillance to all PCI-free SRM patients appears safe with intermediate follow-up, although long-term oncological control requires further study in that. So by this, they probably do not. I don't think it is written anywhere that this percentage of patients there. So we will go, we will just maybe ignore this particular column, right? We can ignore the worst outcome into these lines, and then I think we can interact. In the meantime, I would just go through the article and let you know this. Dr. Amlesh, can we go ahead with the slide?
Please go ahead.
Yes, Naveen, go ahead.
Yes, sir. Among TI outcomes, out of 30% PCI positive patients, 78% underwent delayed intervention, 22% deferred due to poor health or personal preference, one PCI negative patient crossover to DI due to anxiety, and median time of DI was 18 months. Histologic concordance between, with biopsy and DI was 100% for malignancy and 97% for other histologic types. And the delayed intervention that was done was nephron sparing surgery. Here the 1, 2, and 3 years DI-free survival rate were 96%, 81%, and 75%. The worst outcomes with initial diameter more than 3 centimeter, initial 3 centimeter, tumor volume more than 5 centimeter cube, clear cell RCC, initial renal score more than 7, and Charlson index less than 1 were 55%, 67%, 46%, 65%, and 63% respectively. 62% were found to be Fuhrmann grade 3 or PT3. So in discussion, most active surveillance patients remained PCI free and treatment free for study duration. None developed metastasis. Those who converted to resection typically had aggressive pathology. Despite initial conservative management, there was no oncologic compromise. It supports for oncologic safety of SRM treatment delays. Only one patient had TI conversion rate for that is due to anxiety, and no adverse pathologic risk was seen in delaying treatment for 6 to 12 months. And minor growth was seen, that is 0.7 and 0.2 mm per year, centimeter per year. No difference in rates of partial or radical nephrectomy or post-op morbidity was seen. No renal preservation was compromised, and several features that are identified as high risk for PCI or DI. They were longest tumor diameter is more than 3 centimeter, renal score more than 7, clear cell RCC histopathology, and about half of the patients required DI within the 3 years with presence of one or more of these factors. The limitation of this study was heavy selection bias for intervention unfit patients, and the small cohort and limited data with short-term follow-up, unclear progression, sometimes long-term cancer control, and for metastasis, long-term follow-up was needed. Additional studies are needed to define PCI threshold. It was single urologist study, and no direct comparison was done between the surgical or ablation series. So conclusion was broadly recommended, the authors broadly recommended active surveillance among PCI negative patients, otherwise unselected SRM patients, is a novel approach that can identify at-risk patients for further intervention. And particularly in the COVID era that has been marked by the treatment delays for unconventional reasons, it is reassuring for patients for active surveillance and PCI who are for this study who had fulfilled the inclusion criteria as seen in this article. And in the interim, additional investigation into broader active surveillance uses among SRM patient is warranted. And they provided.
Naveen, go back to the previous slide.
Yes, sir.
Yes, previous.
Yes.
Okay, now here the first conclusion that you have made is in limitation, heavy selection bias for intervention unfit patients in prior active surveillance series. We are not going to talk about prior active surveillance series. If you're going to talk about limitation, then you have to talk about limitation of this study. The discussion is regarding, in Journal Club, the discussion is regarding this study. So you will not bring out the limitations of previous studies.
Naveen, does that mean that about the previous series?
Yes, sir. This means.
So when we are discussing this study, how you should not have brought this out. Dr. Seth is very clear and is very correct on this.
Yes. Sorry, sir. This was my mistake.
Right. So, Dr. Seth, I would just read out the first page of the article, which says what we found. So, of 128 SRM patients over 4.75 years, 123, that is 96%, lacked PCI at presentation. and all 123 were recommended AS, that is active surveillance. With median and mean follow-up of 31 and 34 months, no active surveillance patient developed metastasis and only a minority, that is 30%, developed PCI, of whom most 78% were converted to DI, that is intervention. Broadly recommended active surveillance was well tolerated, with only one patient converting to DI without PCI. PCI effectively identified more aggressive cancers, evidenced by high rate 62% of PT3 and or nuclear grade 3-4 pathology in DI resections, including zero benign tumors. 3-year PCI free and DI free rates were 72% and 75% respectively. So it doesn't say anything about those percentages that he has mentioned. I think he has wrongly written those percentages. So most of these patients who were on active surveillance and were not given DI, none of the patients, only one patient developed a lesion which needed intervention later. So in their conclusion, the active surveillance had quite a satisfactory result in most of the patients.
Even the one patient which required DI, even the one patient which required DI, he required DI because of the patient's own anxiety and, because of his concern that it may convert into malignancy or later on. It was not actually, he did not fit into the criteria for DI.
So 30% needed DI.
Yes, sir.
And out of 30%, only one patient was the one who had DI because of anxiety. The remaining
without
had
PCI.
DI,
Without PCI.
Without PCI. Without PCI. So almost these 30% had PCI on active surveillance, so they were shifted to DI.
Okay, so Naveen, what do you learn from this exercise today?
Sir,
So what were the faults in the journal club presentation? I am not talking about the faults in the study or whatever. So what were the mistakes that you made in presenting this journal club?
So I had to study the journal more thoroughly, and I have made some mistakes that should be removed. Like this, I have put this limitation of previous year series in this series. That is my mistake, sir. I have to read it thoroughly.
Yes. So the journal club, whenever you are presenting a journal club, number one, you should read the journal completely. You should understand each and every small thing. Only then you'll be able to convince the others. Only then you'll be able to talk about it authoritatively. And in the journal, you have to find out what is the patient population that you're talking about. So there are 4 things: patient, intervention, comparator, and outcome. So all these 4 things, PICO, all these 4 things you must understand completely. And then you have to check for the validity of the study. So whatever is whether this study actually achieves the purpose for which this study was designed, whether the study design was appropriate for the purpose for which the study was done, and then whether the intervention was appropriate, whether the outcome measures were appropriate or not, and whether the conclusions are appropriate or not. Then so you have to analyze the study very properly, and then you have to give a comment whether the procedure that was followed correct or not. Okay, whether the selection of patients was correct or not, whether the comparator that was used was appropriate or not, whether the outcome measures that were used, whether they were appropriate or not, and finally, whether the conclusions are appropriate or not. Okay, and then after this comes the external validity. Whether this study can be applied to your conditions or not, or whether it can be applied generally to other situations or not, or whether it is appropriate just for that particular subset of patients. Okay. So these things you have to understand whenever you are presenting a general plan. Okay. So we can go to the next one.
Right. So in the meantime, just I would like to ask a few questions. Yes, Neeraj, you have any queries?
No, sir, just you can go ahead with the discussion, sir. We'll discuss with sir.
Okay. So one thing is probably
Sir,
we might.
sir,
Yes, who is there?
Sir, Prashant Gupta.
Prashant, yes.
Good evening.
Good
Good evening,
evening.
sir. I have a query in presenting a journal club. What I know we should tell the limitations also of this particular article, that the study is done properly or not, or selection to what Amlesh sir is saying. But
Yes.
that comes under limitation or not, as the Naveen is showing.
Yeah. So definitely for the article, we need to say about the strength and weaknesses of the article particularly.
So that is the particular limitations of this article. Na?
Which one?
All things, what are the policies in this article that comes under the limitation if the number of patients are less and the proper study is not done,
That is under limitation only. Yes.
Prashant, he has mentioned these limitations. These limitations are of this present study or present article only. Like it's a single study, it's not a multi-centric study. Then he has not compared.
That's what I'm saying.
Yeah. We should write.
सर बोल रहे थे कि लिमिटेशन को नहीं बताना है अपने को.
No.
Misunderstood. Sir ने कहा कि previous studies को नहीं बताना है.
No, limitations have to be brought out. No.
Limitations have to be brought out. Previous study का limitation नहीं बताना है बेटा. माने कोई previous study. हाँ. ठीक है. So Dr. Said, my query is, do you routinely do a needle biopsy in SRMs in your center?
No. We don't do it, and we follow the standard guidelines that whenever the biopsy is likely to change the outcome, and the standard guidelines for those are: number one, if you suspect that to be an infected focus, if you think that it is a metastatic focus, if you think it's a lymphoma. So these three are classical. And number four, in a situation where the operability is where the surgical fitness is borderline, and you want to decide whether the patient has a benign disease or a malignant disease, and therefore you want to risk stratify the disease versus the risk in that particular individual. Which means that if a patient if a patient is fit surgically, then he'll undergo surgery. If the patient
even an SRM patient of 2 centimeter size tumor will undergo surgery in your center?
If the patient is fit, and if the lesion, because in our setup, what we normally do is, if CT is not categorical, we get an MRI. And in MRI, there are number of sequences that they do, and they tell us more categorically whether it's likely to be benign or it is likely to be malignant. So we have that advantage. Instead of relying on biopsy, we rely more on imaging. And in doubtful cases, we don't rely just on CT scan. We add at least one more imaging modality, and that is generally MRI, or sometimes it is contrast enhanced ultrasonogram, depending upon whether it is partly cystic or mainly solid.
Okay, so all these tumors, you never put them on active surveillance. So if you think this is a tumor, you would not put the patient on active surveillance.
No, if we think it's a benign, which means if the enhancement criteria are not fulfilled.
No, enhancement is there definitely. So that is one of the inclusion criteria. Yes. Enhancement is there, then you would always do a partial nephrectomy, right?
Yes, we will go ahead.
Even if it is a 2 centimeter tumor, you would not monitor the patient, you would go ahead with the nephrectomy.
I'll explain it again. If the enhancement is more than 20 Hounsfield units, then it is likely to be malignant. If the enhancement is less than 10, it is likely to be benign.
Right.
If it is between 10 and 20, then it is borderline.
Yeah.
So if it is borderline, then we have two options. Either we do a biopsy, or we do another imaging modality.
Okay.
What we follow in our center is that we do another imaging modality.
Okay.
For solid lesions, we do multi-sequence MRI. For cystic solid lesions, we do contrast enhanced ultrasonogram. So
Okay.
if contrast enhanced ultrasonogram is suggestive of malignant, then we again advise surgery. If it is suggestive of benign, then we follow these patients up. Similarly, on MRI, they do some bold sequence, etc. They have some sequences. And if
Yeah.
that is suggestive of malignant, then we go ahead with surgery. If that is suggestive of benign, then we keep the patient on active surveillance. This
Okay.
stratification can be done either by imaging or by biopsy. In most
Okay.
centers, yeah. So the 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 advantage of biopsy is that you have a tissue, but sometimes you may not hit the diagnostic area, and sometimes you are landing up with oncocytoma versus oncocytic RCC. Biopsy cannot distinguish between these two conditions, and in all these mainly borderline situations, you will actually have either an oncocytoma or oncocytic RCC. In
Okay.
CSL RCC, generally uh, the imaging would be more diagnostic, and in cystic it may be borderline. So those who have a high grade papillary, those who have a high grade cystic, high grade clear cell, the likelihood of imaging picking up is very high.
Okay.
It is as good as
Neeraj,
biopsy or perhaps better than biopsy.
okay. Okay. Neeraj, go ahead. Yes.
So I just wanted to make a small comment regarding
Yeah.
this biopsy issue.
Yeah.
A few years back, there were concerns about doing a biopsy for small renal masses, like there would be, concern of tract seedling and, issues of hemorrhage and all those things. But over the last few years, more and more people are resorting to biopsy, especially in small renal masses. That is because whatever imaging study that we do, that is, even if you do a contrast MRI or a CT or contrast ultrasound, they are not, 100% diagnostic in actually telling us whether it's a benign or a malignant pathology. And if you analyze the final histopathology after these excision of small renal masses, almost 30 to 35% of them would turn out to be benign. And it would be, I think, an over treatment for these patients whom we have, subjected to some sort of a surgery. So don't you feel ki for small renal masses, which are, not very characteristic of RCCs, we should be doing biopsies more often in these patients, sir?
Yes, what you have said is right, that for small renal masses that are not very strongly suggestive of RCC, we need to know whether it is benign or malignant. And the ways of knowing this are either we do a biopsy, or we do another imaging, or we follow them up as has been done in this particular paper. Okay, so now we have to see what is the reliability of the biopsy in this situation versus the reliability of adding another imaging modality. So if you look at the reliability of contrast enhanced MRI versus the reliability of biopsy, that is what you need to look at. I think we need to do a randomized study to do that, but at the present time, both are considered viable options.
Yeah.
And both are not considered sacrosanct. It's not that biopsy is 100% diagnostic or contrast enhanced MRI is 100% diagnostic. Both have their own limitations. Even the biopsy series would show the reliability to the tune of maximum 90%. Maximum 90%. Duet series, etc. Those that are the best series done in best centers with accurate positioning of the biopsy needles, etc. Most experienced people, there the biopsy reliability is 90%.
Right. So I think, yes, you are right. But now we have many studies which are saying that probably SRMs, they are doing biopsies routinely. Anyway, just last comment on the focal ablation of these tumors. So are you doing focal ablation also for SRMs in your center?
Yes, we are doing. We have a radio frequency ablation, and that is being done by the Department of Radiodiagnosis. We don't have cryo, we don't have electroporation, and radio frequency ablation, we don't have HIFU. Radio frequency ablation is done in patients who are not fit candidates for surgery.
Okay. So only those patients who have comorbidities or not fit for surgery, you would go ahead with RF ablation. All right.
Yes.
All right.
That is what mainly we are doing.
Right. So we will go ahead with the presentation. Naveen, go ahead with the second presentation, please. Go ahead.
Yes, sir. So meanwhile, I got that line from where that 49% issue I got. So that was PCI free survival. So that was not overall survival. That was my mistake.
Yeah. PCI free service. So that has totally changed the whole thing, right?
Yes, sir.
So Naveen, you have to be very careful when you are trying to interpret the article, right?
Yes, sir. I'm extremely
Okay.
sorry.
Go ahead with the second presentation.
Yes. So next topic is radical cystectomy against intravesical BCG, that is maintenance BCG for high risk, high grade non-muscle invasive bladder cancer. Results from the randomized controlled Bravo feasibility study. The purpose was high grade non-muscle invasive bladder cancer. It is a heterogeneous disease, and we have treatment options of intravesical BCG, induction and maintenance, or radical cystectomy. They wanted to understand, the authors wanted to understand whether a randomized trial comparing these options was possible. So introduction is bladder cancer. It is a common malignancy, one of the most expensive to manage. About 25% patients have high grade tumors, and rate of progression to muscle invasion vary between 15 to 50%. 20% may die from bladder cancer, and progression risk include presence of carcinoma in situ, invasion into lamina propria, or prostatic urethra involvement. And in this study also, they have used these features for defining high risk, high grade NMIBC. The treatment options were, as I have already discussed, it is the BCG or radical cystectomy. Although maintenance BCG avoids bladder removal, it has some issues with health related quality of life. Patient have local symptoms and anxiety, and also they have the risk of progression. On contrary, radical cystectomy removes the risk of local disease progression. But again, here we have some issues related to health related quality of life. They may have post-op complications, and even 3% died after 90 days. Radical cystectomy and maintenance BCG have not been directly compared, hampering decision making and exposing patients to overtreatment or undertreatment. As RCTs comparing radical surgical with non-surgical options are challenging to complete, they hypothesized that recruitment and random assignment would not be possible. And around 10% patients with new high-risk NMIBC have a lethal disease and may be better treated by primary radical treatment. Conversely, many are suitable for bladder preservation and may maintain their pre-diagnosis quality of life. And material and method, this was done by James W.F. Cato et al. It is multicentric parallel study. Mixed methods were included, and it was individualized. It was randomized control study, and it was published in Journal of Clinical and Oncology on December 2020. Total number of patients included were 50, and the study period was 18 months. It was not possible to blind treatment allocation, and patients were consented by the clinicians and randomly assigned in 1:1 ratio by the clinical trial research unit. Random assignment was stratified again by the age whether it is less than 75 or more than 75 years, according to gender, center, highest transurethral resection of bladder tumor stage of TA, TIS or T1, the presence of CIS and the previous low risk BC. Re-resection was performed if the initial resection was incomplete or bladder muscle was not found. The randomly assigned cohort were typical for bladder cancer patient, mostly were men in 4:1 between the age of 60 to 80 years with a smoking history of 74%. The inclusion criteria were patients were of more than 18-year age with a new diagnosis of high grade or grade 3 non-muscle invasive urothelial carcinoma, and one or more criteria from presence of PTIS, lymphovascular invasion, residual grade 3 or high urothelial carcinoma on re-resection, multifocal disease, that is more than 3 tumors, young age of less than 65 years old, initial tumor size of more than 3 centimeter or PT1 stage, they were also needed. Exclusion criteria was known BCG toxicity, unfit patient for surgery, not giving consent, or low grade tumor. Primary outcomes were the number of patients screened, eligible and recruited and randomly assigned in the study. Secondary outcomes were the acceptance rates of the allocated treatment, 12-month BCG compliance, feasibility of collecting health-related quality of life data, and to explore the reason expressed by patient for declining recruitment. The treatment was given. Successful maintenance BCG was defined as more than 4 induction doses and at least 12 months of maintenance treatment using the SWAP protocol. And maintenance BCG could continue in the presence of high-risk NMI-BC at first cystoscopy after induction of BCG or in the presence of low-risk NMI-BC at any time. The presence of high-risk NMI-BC or invasive BC after induction required cessation or maintenance BCG. Rigid cystoscopy and biopsy, bladder washings, urine cytology was mandated at the first check, and dose adjustment for BCG was not permissible. Radical cystectomy included the removal of prostate seminal vesicles in men, uterus, cervix, fallopian tubes, and anterior vaginal wall in women, and pelvic lymph adenectomy was done, including regional lymph nodes. A minimum of average of 10 lymph nodes were removed. To minimize surgical variation, only they have defined the even criteria for surgeon with more than 10 years of radical cystectomy experience, or they have certification from British Association of Urological Surgeons data set 20, or more than 10 RC per year experience, or in the last year they have done 20 RCs with a median length of stay of patient is approx 16 days and 90-day post-radical cystectomy mortality less than 10% were used. Follow-up was done as per 3 monthly clinic review. Chest or abdomen pelvic CT was done at 52 weeks after the random assignment. Health-related quality of life questionnaires were asked before treatment allocation and at 3 months, 6 months, and 12 months. Death, complication, adverse effects up to 12 months or were considered, and qualitative and quantitative assessments were done. In results for maintenance BCG, 23 patients out of 25, that is 92%, started BCG all within 4 weeks of assignment. And among these 22 patients, they received all induction doses, and one had 2 omissions because of BCG-itis or urinary infection. At 4 months, low-grade PTA and high-grade PT1 NMI-BC, they were present in 1 and 2 patients respectively. At follow-up, 1 patient has progressed to distant mets, and 4 patients had received radical cystectomy, 2 because of the initial preference. 1 has CIS in subsequent clinical examinations and in check cystoscopies, and 1 because of ineffectiveness of the BCG post-induction. So 1 patient was received hyperthermic mitomycin C. In total, those who commenced BCG treatment, 5 permanently discontinued BCG. Radical cystectomy, in radical cystectomy, patient results are as follows. In the radical cystectomy arm, 20 patients out of 25, that is 80% received the primary treatment, that is RC, within 8 weeks of random assignments. Most surgery was done as open approach with ileal conduit. One case included synchronous urethrectomy, and one patient required blood transfusion, and radiological guided drain placement was there for one patient for pelvic collection. 5 patients experienced 5 adverse effects related to cystectomy, hemorrhage, bleeding, small bowel injury, nerve injury, and difficult dissection. 6 patients experienced 9 post-op complications like chest infection, wound infection, ileus, urinary constipation, and consequently, participant had an increased length of hospital stay. And there were no deaths within the follow-up period. And by 6 weeks after the surgery, 9 patients had different complications. I will divide it at 6 weeks, 20 weeks, and by the end of 52 weeks. By 6 weeks, 9 patients have developed complication: the anastomotic leak, constipation, sepsis, ileus, wound or urinary infection. 3 patients had a prolonged length of stay, and 4 required readmission. By end of 20th week, further 5 complications were seen as abdomen pain, fever, sepsis, low vitamin B12 and folate, and no further complications were observed by the end of 52 week. Histopathology revealed high-grade urothelial carcinoma in 15 patients out of 20. 5 patients have no tumor in their histopathology, and in 15 patients where we got high-grade urothelial carcinoma, 13 were having the NMIBC in PT1 and PTIS stage. 2 patients had muscle invasive urothelial carcinoma. Lymphadenectomy was performed in 19 patients with a median of 10 nodes were removed, and no nodal metastasis was detected. 4 patients had urothelial carcinoma at the urethral and ureteric resection margins. Now, regarding health-related quality of life data for maintenance BCG, there were a small increase in the urinary symptom scores at the 6 month and concern about contaminating a partner at 3 months, although it was reduced by the end of 12 months. For radical cystectomy cohort, most symptoms improved from 3 to 12 months, except sexual function, but did not change. So in discussion, failure to recruit was multifactorial. BCG is often the default first-line treatment because clinicians feel feeling of unfitness of the patient for radical cystectomy. They found although 2 out of 3 of screened patients were of 70 years old and 3 out of 4 had a smoking history, but most were just fit for either treatment by urology and anesthetic staff. Clinicians often manage high-risk NMIBC as a non-lethal disease, but the authors found it as high risk of progression. And in the participants randomly assigned to radical cystectomy, 2 had muscle invasive bladder cancers. So, and 1 had the even prostate cancer of Gleason 4+3, that is 7. And this patient received, and some patient received re-resection, and for the other patient who have the prostate cancer, they were cross-sectionally imaged and reviewed by the multidisciplinary meeting and had seen specialist uro-oncologist. In BCG arm, 2 participants developed metastasis during the follow-up. Thus, 10% of patients with new high-risk NMIBC, they have a potentially lethal disease. Finally, patients fear radical cystectomy as they perceive a low health-related quality of life. Within the first 3 months, health-related quality of life may be superior with maintenance BCG to RC, but after 12 months, they both were equal. The differences were disappeared. In the radical cystectomy cohort, 25% patients had no tumor in their cystectomy specimen, and other 10% have invasive cancer. The limitation was long-term follow-up was needed, as this study was for 18 months for oncologic outcome and health-related quality of life, and size of cohort was small. It was 50 patients. So in conclusion, findings may suggest that radical cystectomy has superior oncologic outcome with limited impact of health-related quality of life, but the authors have advised to prioritize the treatment on patient-to-patient basis as per consent and the patient's individual preference. And the second objective was to conclude whether this study was possible or not. So they have mentioned the study was designed to test feasibility of a larger trial, and so findings with respect to urethral carcinoma outcomes or impact of health-related quality of life are underpowered and need to be interpreted cautiously. Thank you, sir.
Thank you. So we will invite your comments, Dr. Seth.
First, I'll just answer Prashant's question. You know, my statement was that conclusions from previous studies should not be included in the conclusions of this study, or limitations of previous studies should not be included in as the limitations of this study. Right. But limitations of this study have definitely to be pointed out. Right. That is one of the very important purposes of the journal club.
Right.
Regarding this particular journal, in fact, it's a very difficult kind of study to do, comparing a radical cystectomy with a totally non-surgical. And in our Indian setup, I tell you, whenever we invite patients for even a tablet versus no tablet, most patients say no. They say no research. No. We are not going to be guinea pig. You tell us what is the standard treatment. Even if it has adverse outcome or whatever, you tell us what the standard treatment is. Slowly, we are getting people who understand the importance of volunteering as research subjects. But I have seen in the Western world, the patients come out, they do understand the importance of volunteering, and they do understand that their volunteering may help the future generations. But that is something which is not easy in our Indian setup. And if they found it difficult in the UK setup, then you can understand how difficult it would be in our setup. Yeah. And yes, it is a very difficult kind of comparison. But I think Naveen did a very good job. He brought out all the relevant issues, and he summarized the paper well. And otherwise, and also, I think the paper that is written is also a well-written paper, because, you know, they have brought out all the difficulties of radical cystectomy. The 30-day complication rate, the 90-day complication rate, the 52-week complication rate, and they also brought out the problems with BCG, because maintenance BCG also has its own problems. Because in one study, it was found that at the end of 3 years, only 30% of the patients would complete the entire course, which means 70% would not complete the intravesical therapy maintenance course itself. So that is also one limitation of use of BCG in the practical scenario. So all these issues have been brought out relatively well in this paper, and Naveen has summarized and brought out these points reasonably well.
Right. So I think this is a very kind of a challenging topic. And as you said, randomization probably maybe not possible, but we can have a non-randomized study definitely there, because we have patients who would opt for conservative therapy. We have patients where we go ahead with radical cystectomy with the same criteria. So definitely we can do a study which may not be a randomized but non-randomized. Definitely this study, 2 patients had metastatic TCC after when they were put on conservative therapy. So probably the results were definitely poorer when the patients have been put on maintenance BCG rather than not radical, because all radical cystectomy patients survived and there was no mortality, and there was no, during their follow-up period, there was no recurrence. So I think in that way, so my question is, what is your protocol in your center? If it is a case of high-grade, high-risk, non-muscle invasive tumor, how do you proceed in these patients?
Yes, you brought out this issue very correctly. We generally tend to believe that muscle invasive disease is a high risk disease and non-muscle invasive disease is a low risk disease. This is not, this is not, this is not a appropriate statement. In so many situations, the non-muscle invasive disease would also be high risk disease.
Right.
And therefore, one has to look at in T1 disease also. In T1 disease, obviously, it has to be restaged to correctly, categorically decide whether it continues to be T1 or it is T2. If it is T2, then obviously patient undergo radical cystectomy. If it continues to remain T1, then in our center, we do follow this conservative approach of advising intravesical BCG, but we look at other things also. We look at whether there are multiple areas of carcinoma in situ or not. And number two, what is the depth of invasion? So we know that a patient who has a T1 disease, high-grade T1 disease, has at least about 20 to 30% chance of progressing to muscle invasive disease over the next 2 to 3 years and a need for radical cystectomy. And if the deeper part of the lamina propria is invaded, then that goes up by another 10 to 20%. And if there are multiple areas of carcinoma in situ in addition, then that further goes up by 10 to 20%, which means if all the three high risk factors are present, then there is about a 50% or 60% chance that the patient would need a radical cystectomy over a follow-up period of 2 to 3 years. Then we can talk to the patient and explain it to the patient that if you undergo BCG therapy, despite you have a 40% chance of saving your bladder, but at the cost, like in this particular case, you saw 2 patients had metastatic disease. So there is a 10% chance that you may actually lose the opportunity for cure.
So that is very high. 10% is a very high rate.
10% is a high, but at the same time, most patients would say that, okay, I have a 40% chance of preserving my bladder and I would like to take that chance. Most people actually believe in luck. Most people believe in God. Most people would say that I will not fall in that 10%. I will remain 90%. But yes, but we do explain, at least that is what I do. I do explain it to the patients, those who are intelligent enough to understand. And most people are, even if they're illiterate, they do understand these basic things, that they have a 60% chance, 50 to 60% chance of needing a radical cystectomy if they follow very carefully, and they have a 10% chance that it may become inoperable. But at the same time, radical cystectomy, you look at the radical cystectomy series also. Fortunately, in this particular cohort, the mortality was zero. Mortality was zero, but mortality is not zero. Radical cystectomy mortality in most series is 5 to 6%. Although the textbooks say 2 to 3%, but if you actually read journals and read the series, in series the mortality would be 5 to 6%. We also analyzed our data of about 600 patients, and our mortality was also about 6%.
Right.
So we should be honest and accept that radical cystectomy has a mortality of about 6% and not as low as 2%. In this particular series, the patients were highly selected. They were very early disease. They underwent what is known as early radical cystectomy. Despite that, although mortality was zero, but morbidity was not less. The almost prolonged ileus,
but the adverse events were not very serious. It was
urinary leak, all the complications were there. All the complications were there.
It was about 30%. The morbidity of RC in this particular series was almost around 30%. So, which I think is a bit high, considering
which is a bit high, considering that this was early cystectomy in patients who had minimal disease, almost like a nearly normal bladder.
Right.
But But I tell you, this is a fact.
This is a fact, right?
This is a fact. So it is an appropriately reported factual statement.
Right.
Morbidity of radical cystectomy is also high. Morbidity of BCG is also high.
Exactly, because they have compared them two and they are almost the same, identical. Even with BCG, the adverse events were almost equal to those with radical cystectomy.
So my personal hunch is that if immuno-oncology gives better results than BCG, then maybe that may be the future. But we have to look for it. I mean, we have to wait for the results. And at the present time, what in our center, what we are following is what is the standard given as per the books. Most patients will undergo BCG therapy. Only if they progress on BCG, then only they will undergo radical cystectomy.
So suppose you will do cystoscopy at every 3 months, 6 months, and if
Every
you
3
find
months.
there is recurrence, then only you will go ahead with radical
If there is
cystectomy.
a recurrence which is high grade, then we'll go ahead with surgery. But if there is a recurrence which is low grade, then we'll go ahead with the TURBT.
Okay. And
another important issue is the age of the patient. I think the age of the patient should also be a very important concern in deciding whether these patients stay on BCG or you put them in the radical cystectomy group, because bladder cancer malignancy in a younger age group is always more aggressive, and these patients are bound to have recurrences sooner or later. So younger patients, I think, more would be suitable for the radical cystectomy, high grade tumors.
And on the other hand, if the patients undergo radical cystectomy and do not have complications and they have limited disease, they will live for 15 years. There are good 15-year survivals also known in these patients who have very early disease and undergo radical cystectomy.
yeah, right. Any role of partial cystectomy? Like many of these patients, yes.
No.
A partial cystectomy, many of these patients who are non-muscle invasive, if there is a single focal tumor, do you think there could be an indication for partial cystectomy also?
No, because partial cystectomy will work only in those who have low-grade disease, and in those who have low-grade disease, TURBT will generally be adequate. And those who have high-grade disease, those who have they will have a very high local recurrence rate.
Non-muscle invasive. We are talking about non-muscle invasive high-grade disease. We are not talking about muscle invasive disease. Muscle invasive, definitely.
Yes, non-muscle invasive high-grade disease also means that biologically they have a biologically bad disease. Their likelihood of having carcinoma in situ at other places in the bladder is high. You look at this series also. 1, ureteric margin positive, 2, urethral margin positive.
Yeah. So what was done actually that also should be probably should have been brought out, because there were margin positive, urethra margin positive also, and ureteric margin positive also. Yes.
Yes, 3 out
so
of 20.
I think one. So in this also they have said that the criteria for choosing radical cystectomy could be like patients who have a hydroureteronephrosis. So even if this is a non-muscle invasive but hydroureteronephrosis, we may do a radical cystectomy in this patient. And then they have said about, as you said about the deeper tissue lamina propria, because now we divide T1 into 1A and 1B, and 1B is when the deeper lamina propria is involved. So if it is 1B, probably we should think more towards radical cystectomy, doing towards more radical cystectomy. Right? And then they have said about if the prostatic stromal or ductal involvement is there, or if lymphovascular invasion is there, or if there is a variant histology, definitely all these would favor a radical cystectomy over maintenance BCG.
Sir.
Neeraj, go ahead.
Sir, I just wanted to, I wanted sir to comment about the role of bladder conservation in non-muscle invasive bladder tumors. Like I know we are doing combined chemo radiation for muscle invasive bladder cancers in some patients. Have you encountered any series where they are doing bladder conservation in non-muscle invasive bladder tumors also, sir? giving chemo radiation for high-grade superficial bladder cancers?
No, 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 no. Radiation is a strict no-no because radiation may actually increase the risk of recurrence in those who have non-muscle invasive disease, and chemotherapy is not going to be effective. Immuno-oncology is something which is coming up.
Yeah.
Systemic pembrolizumab
Pembrolizumab.
P-series has already come, and Dr. Ashish Kamath, Dr. Badrinath Kuneti, they were all collaborators, and that series has just been published, I think, last month only, and that's the first one for pembrolizumab, and the results are good. But then this is the first series that has come, and we have to look at other series. And if the ultimate results of Pembro or one of these is good, then BCG may actually go out and these may come in.
Right. So maybe this Pembro, and sometimes even like now we are having studies with intravesical gemcitabine, intravesical gemcitabine and HIVAC also, that may increase the absorption and may slightly help better than the usual intravesical therapies. So all these may probably improve the chance of survival of these patients with bladder preservation. So
BCG is also being compared to two drugs, gemcitabine and cisplatin, or gemcitabine and mitomycin.
Mitomycin, yes.
Alternate week.
Right.
So instead of BCG, two drugs can be given, or HIVAC can be given, or yes, this Pembro is also. All these are being studied. Yes.
Yeah.
Yeah, sure.
I think again, yeah, that's I think yes, it was a very good interaction, and I think these two, the chosen articles, are really a very controversial subjects and challenging subjects. We do not have the answers still with us, and most of us would do it what we think to be correct, and. So I think thank you once again, Dr. Seth.
Thank you so much.
Neeraj, you can just wind up the session with your vote of thanks.
Right, sir. Sir has enlightened us with his wisdom and his long experience on two very controversial topics. And I hope the residents have benefited from his immense knowledge. I thank you, sir, again for sparing your valuable time and coming to our academic class program. And thank you again, sir. Thank you.
Thank you very much.
Thank you, Dr. Seth. Thank you. And good night.
Good night.
Good night.
Good night. Good night. Good night.
Good night, sir.
So are we done, right? Hello? So now we'll